Right, psychotic disorders, like all the other disorders we've discussed, have a basis in natural selection. Makes sense that there's got to be parts of our brain that are paranoid in order to detect danger, in order to protect our survival and reproductive fitness. Challenging conventional truths is the foundation for a group to have scientific innovation. So, for example, it was believed for millennials that the Earth is flat. Someone comes around and says, no, the Earth is round, and hence you got scientific innovation. You need that you need people who think outside the box. Loose associations promote learning and creativity. I showed you earlier on how Dr. Seuss uses a lot of clang associations and other loose associations in order to teach children how to read. And belief in the occult or religion also can confer an advantage to social groups, and it can make them more cohesive, and again, that can make the group survive. And really, every now and then you might be on the train and look over at the person sitting next to you and see all of this. You can be pretty sure that this individual is psychotic. Another case where a picture says 1,000 words. What does it mean to be psychotic? A loss of reality testing. But there's quite a bit more, which we will discuss. So these are the psychotic disorders, which we will talk about now. First, schizophrenia, which was described as the worst disease affecting mankind, even including AIDS. There are discussions about schizophrenia going back 2000 before the Common Era. And although schizophrenia means split mind, it is not about a multiple personality disorder. There are 5 major features in schizophrenia, and you don't have to have all of them, just 2 or more to be qualified as having schizophrenia. Delusion we've described, fixed false belief, hallucination we've talked about. Thought disorder we've also talked about, that's the loose associations. Bizarre behavior or appearance. Person does something like wearing a heavy coat in the middle of summer. And then negative symptoms refer to anhedonia, social withdrawal, no motivation to do anything. So for schizophrenia, the DSM-5 criteria, you need 2 or more of those 5 classification of symptoms. There's got to be some social or occupational dysfunction. The symptoms must be continuous for at least 6 months, although if they were given treatment before the 6 months, one can still call it schizophrenia, although it requires the judgment of the clinician. So a delusion we talked about is a fixed false belief. It's not accepted by other members of the person's culture. So if there is a belief that is part of the individual's culture, it cannot be called a delusion. And here is Richard Dawkins calling God himself a delusion. But we wouldn't call all religions delusional because they are accepted by people within a specific social group. A whole wide range of delusions I've listed here. The most common one is persecutory delusions. And there's some very interesting name delusions. Capgras syndrome is when an individual feels that a significant other or child or somebody close, their body's been taken over by an alien force. Dorian Gray is when a person feels like everybody else is getting older, but he looks in the mirror and he's just staying the same. Frigoli's phenomenon is when there's a single persecutor that hops from person to person and invades their bodies, and so that persecutor is always following you around. Doppelganger is the belief that you have a double. Othello is erotomania. Intermetamorphosis is when an individual, actually I've got an example of intermetamorphosis that I'll show you shortly. Lycanthropy is the belief that one turns into a werewolf. My personal favorite is phantom boarder. That's when a person believes that there's someone else occupying their home, even though obviously there's no evidence that that's happening. So a phantom boarder. Delusional incubus. Delusions that one is having sexual intercourse, often with a deity. And then Cotard syndrome is delusion, same as delusion of nihilism. It's the belief that you are dead. And let's show a little example of that.
The epi isn't working. I still don't have a rhythm. Transcutaneous pacer isn't capturing. Pupils are fixed and dilated, I'm calling it. Time of death, 9:17.
I always thought that when I died, I'd see a bright light or float above the ground. Turns out death is pretty mundane. I guess sometimes the end is just the end.
For the last time, Jerry, you're not dead, okay? Now go back to your room. Jerry has catarrhs, or walking corpse syndrome. The guy thinks he's dead even though he's walking around.
How you doing?
Not great, actually. I'm dead.
Bummer. How long?
4 years next month.
Jeez, that's a nightmare. I was dead once, for about 10 minutes. Then my mate Danny peed on my head.
Really?
It's quite a sight to wake up to, though.
When I was alive, I wished I had lived one day like he lives every day of his life.
Dead people don't talk, Jerry. We weren't really mad at Jerry.
You don't need to know the names of these delusions. I just wanted to make the point of how interesting it is that people who've never met each other, who've never read anything about this, in different states, different countries, can have delusions like this that are just so stereotypical, like who would have thought of Dorian Gray or Fragoli's phenomenon, and yet it occurs in people that have no connection to one another. So there must be something in our brains that if a switch is turned on, will have this entire story behind it. So this is an example of inner metamorphosis in a patient with Alzheimer's disease. I'm just going to read what's in yellow, and you can read the white yourself. It's a 76-year-old right-handed man, 3-year history of progressive decline in memory and cognition. About 2 years in his illness, he began misidentifying family members. He misidentified his wife as his deceased mother, and later he thought his wife was his sister. Gradually, he began misidentifying his son as his brother, his daughter as another sister, and his granddaughter as his daughter. And these misidentifications persisted even on the telephone, just hearing their voice. He had a mini mental status exam score of 16 out of 30, which is moderate dementia. And what they did is they gave him photographs of familiar people from a photo album going back years and years and years. The results showed 100% misidentification of his wife as his sister, with 100% persistent in the misidentifications over the past. So look at 30 years ago, seeing a picture of his wife, he called the picture of his sister. And he was able to correctly identify himself through all the different ages. The misidentifications were not limited to the visual modality, as they occurred with the person's voices as well. It points to a preservation of the abnormal person identity nodes across time and across modalities. Through looking at these disorders, we see just phenomenal things about the way our brains work. Okay, hallucinations can be auditory, the most common, visual, tactile, smell, and taste. Synesthetic is an interesting type of hallucination, quite rare, but it's when a person feels that their actual viscera are changed. So I have a patient who feels that her joints are made of metal. Another patient would say his pancreas is burning. Those would be synesthetic sensations or hallucinations.
Worthless.
He's waking up now.
Oh, the phone woke him up. Don't answer.
They'll know who you are.
You're a waste of space.
Why are you so stupid?
A waste of our time.
Stupid. So stupid. Worthless. We hate you.
He's gonna pick up the phone.
They'll know if you lie.
Rain! It's
Something
rain!
wrong. Weather.
Now to get pizza.
Poison.
Coming to you. Pizza.
He's hanging up.
Do you hear me?
Don't eat. Out to get you.
Poison.
They know about you.
Cameras
Poison.
were rolling when the armed gunmen entered the convenience store on 14th Street. The suspects were described as medium in stature with a slightly youthful demeanor. Anyone with information about this incident is urged to contact
They know. They know about you.
And in other news, officials have closed the northbound
Time for
lane
meds.
of
Don't do
Boulevard
that.
due to a water main break. Repair crews are on the scene. Now here's a story out of Chicago from last night. Two men posing as maintenance workers nearly made it out of the Quick Bite convenience store with the store's ATM machine.
Make a
The
list.
suspects
Make a
pulled up in
longer
van,
list.
entered the store, asked the
You
customers
are
to not use the
ungrateful.
machine because of
You're a
reported
waste of
problems.
space.
They
A
told
waste
the
of our
clerk that they were
time.
going to take the machine back to the
Getting
shop and
coffee
repair.
now.
Don't drink it.
Sensing something
Stupid.
suspicious,
So
the clerk
stupid.
That
called
smells
local
awful.
authorities.
Don't drink that coffee.
When the clerk told the men he had called police, the pair took off and left the machine.
Why are you so worthless?
So, Sky, tell us how this weekend's weather is shaping
Weather.
out.
Something wrong.
You know what, Chuck? There's just no stopping the weekend weather. You hear that, worthless? Weather's coming to get
Something
you.
wrong. Weather.
And what are you going to do about it, huh?
Something wrong. You have to stop it.
You're just going to sit around with your stupid mouth open and do nothing?
You have to stop it. It's the weather. It's here for us.
Now he has to answer the door.
It's here for us. Do something. Stay in.
Pizza!
Stay away from the
No.
door.
Stop the weather. Protect us.
Pizza!
You didn't order anything. No. Don't answer. You're stupid to open that door. He has to open the door now.
Here you go.
Don't do it.
You'll be in trouble. Poison.
This is for you.
This is for you. He's working with them. He's part of the plot. This is for you. Shut the door. Shut it. Don't eat it. Poison. You're stupid to open it. I hate you. We
Here are
hate
some
you.
items on today's activities calendar. And you need some activities, especially when you're lazy and you sleep too much. Stop staring at me. I know what you're thinking.
He knows. You can't stop
They're
it.
coming for you. You know that.
Part of the plot. Use your mind.
It's because you're so ungrateful.
Don't eat it. Poison.
No. Don't open
He
it.
has to open the
This
box.
is entirely your fault.
Don't eat it. Don't eat it. Poison. Poison.
They're here, and it's all your fault.
Oh.
No.
They know it's you. You're in
Don't
control.
open the
Do you
door.
hear that?
No. Don't open it. Don't open it.
They're here, and it's all your fault.
You did it.
You should have used your mind to stop it.
Stop it. You have to take control.
Stop the door.
Hey! You alright in here? I called you. Why didn't you answer? I was like screaming, "It's Lorraine! It's Lorraine!" into the phone at the top of my lungs.
What were you watching? Do you even remember?
Did the pizza Oh! What happened here? Did you forget to take your medicine this morning? Well, you know it's not good to miss a dose. Well, it's not too late to take it now. Let's get back on track. And why are you standing here in the dark? It's a beautiful day outside. Let some sunlight in. You need to get outside and enjoy it.
This is Louis Wayne, a famous painter who painted cats, who became schizophrenic, and you can see from his earliest drawings all the way as he gets more and more psychotic over time, a nice transformation in his perception of reality. Thought disorder, we've talked about this already, derailment, loose associations, clang associations, etc. There can be incoherent speech, illogical reasoning, concrete thinking, in terms of a person can't abstract, and poverty of thought. So this is usually in connection to negative symptoms, but can also occur, as we've seen in some of our videos. A person can have a lot of words, but no meaning, and that would be a poverty of thought. Bizarre behaviors, like pretty much just read this, and you might recognize some of this on your walk home tonight in terms of homeless people. One of the behavioral abnormalities that we talked about on other videos is catatonia. So 3 or more of these features, and I'll let you read this on your own. Then we've got the 5th feature of schizophrenia is emotional deficits. People have difficulty identifying facial expressions. They have no interpersonal skills. They don't have any desire to be around other people. They can even mislabel their own emotions. They're flat. They're not enjoying anything. They're not motivated. And one of my supervisors once told me it's like you knock on the head and there's nothing there. It's completely hollow. It's the worst constellation of symptoms for someone who's schizophrenic. Is essentially they're alive, but there's nothing in there. Let's look at mislabeling one's emotions.
I understand there was some kind of accident this morning.
Yeah.
Yeah?
Yeah, this morning I got up to get my newspaper and someone had ran over my cat.
Uh-huh. How does that make you feel?
I'm sad.
You're sad?
Yeah.
You're kind of smiling now. Do you feel sad now?
Yes.
Uh-huh. Okay.
So again, schizophrenia is characterized by 2 of these 5 categories for at least 6 months, and not explained by another medical disorder or another psychiatric disorder. Let's put it all together and see this next video.
Gerald S. is grossly delusional and thought disordered. He is currently on the following medications: haloperidol, 32 milligrams daily; benztropine B, 4 milligrams daily.
I'm doing so hot, I think and feel as though people have called me here to electrocute me, judge me, put me in jail, or kill me, electrocute me because of some of the sins I've been in.
Is this a new feeling for you?
The main thing is don't get excited, but the thing is it's not a new feeling, no. I'm scared of people.
Must be very frightening for you, though. Feel like you're about to get killed.
I'm so scared I can tell you that picture's got a headache.
Can you tell me more about that? The picture has a headache?
You want to know?
Yes, I do.
Okay, when a sperm and an egg go together to make a baby, only one sperm goes up in the egg. And when they touch, there's 2 contact points that touch before any other 2. And then it's carried up into the egg. And when they fuse, it's like nuclear fusion, except it's human fusion. There's a mass loss of the proton. One heat abstraction goes up in the electron, spins around, comes back down into the proton to form the mind, and the mind can be reduced to 1 atom.
Jerry, in one patient at one time, shows almost every one of the major features of schizophrenia. His thinking is disorganized. The thoughts are loosely connected. He has formed delusional ideas. Some of those delusions are grandiose. Some of them are paranoid. He has disturbances in his mood. His mood is, in some cases, almost absent, and in other cases is totally inappropriate. And his behavior is disordered. It's unusual. He has mannerisms that are inexplicable. He has purposeless, aimless behavior around the ward. He's a textbook case. He combines all those things in one person.
At this point, what would you like us to do for you?
I'd like you to get me off of cigarettes, get me dried out, cleaned up so I can go home and get a job in a bakery and go to medical school.
Jerry's voices may at times say, "You raped that woman." In a case where he may have just seen a woman on the street, the voices will accuse him of assaulting her. One of the things that worries me about Jerry and about many patients is at times his voices tell him to do things. In just the short time he's been in this program, the voices at times have told him that he's got to leave because we're going to hurt him. So obviously they say things that greatly distress him, that scare him.
It's nice to see you.
Dr. Bigelow's the
Please come in
clinical
and sit down.
director.
Well, thank you for coming down.
Dr. Bigelow?
Morning. How are you?
About to get my teeth knocked out, I feel like. Because I'm nagging people. I'm playing a game with my psychological pain, but it exists.
I know it does, Jerry. That's why you're here, isn't it? To see if we can help you with it.
Jerry, I think the big question today is if you stay. And when you and I met with Dr. Bigelow on Friday, that wasn't very certain, and that's the whole reason that your mother flew out here.
I will stay if my mom stays.
Well, I told you before that I can't stay continuously.
Well, how does that work?
We can come down maybe once every 6 weeks and stay a week, but I can't.
See what I'm doing right now. I understand what I'm doing. I've got you one down and I'm not going to let you up. And that's a game. That just gets you mad.
Truly, deep down, he knows that this is the last chance he's got of having anything and being able to control anything that he wants or tries to do.
Yeah, I can
And he
believe
knows
an
that if he
instant
turns
doubt.
his back on it, that he's had it.
I hate you. Dr. Petrelli in Detroit looked at my transcripts and he started going like this. Gerald, just what could you have done if anything had ever went right for you? Been my boss?
Can I interrupt you a minute? If
Every time in school that I was going to do something, I would raise my hand and a colored kid would stab me in the back of the neck. What is your explanation for that, God? That's what you're afraid to say. What is your explanation for that? Because you can't say it.
My explanation is that you feel that whatever decision you make, you're going to lose here. And maybe that's why it's so hard for you to make that decision.
My dad told me to stay here. I will stay if my mother will stay. There's no pressing job for her. She can have my Social Security check to live on while she's here.
Is that possible, Mrs. Smith?
I told him that we could come down once a month maybe and
You're going
stay
to
a
get me
week.
not scared, so I'm not scared while this dude's playing boogie-woogie with me.
But Jerry, listen a minute. You mean that you can't stay away once a month? Let us come once a month and see you.
I mean, in walked this one old dude with green teeth, and I couldn't think of nothing to do, so I just reached out and kicked old green teeth right in the knee.
Your mom asked you a question.
Jerry,
If I'm not scared, I won't kill
Jerry, it's
you.
important that you listen to me for a minute.
Why, you gonna tell
If
me
you go
Dad's
back,
dead?
if you go back, no, if you go back,
You gonna tell me Snoopy's dead?
You had better listen. Don't think of something else while I'm talking to you. Listen to what I'm
I'm not
saying.
talking to you at all.
Okay, if you go back, you may wind up in a hospital that I won't even get to come and see you once a month.
You are not my...
Do you understand me?
Do you realize this is my mother and I'm trying to keep her alive? Now, what do you recommend, doctor?
I recommend you give her a chance and listen to her.
Don't you think it would be better that you stay here on your own?
No.
Where you signed yourself in?
I don't.
Jerry, I think that you're
You don't know
confused
what-
enough about and frightened enough that I'd be afraid you would hurt yourself if you weren't in the hospital.
Okay, now, you are afraid that I would hurt myself if I wasn't in a hospital. Now, why is that? Because you're
Because
not
of what you
afraid?
said.
Because you're not afraid?
No, from what you said.
I think my dad can treat me very nicely.
Well, I understand that your dad wants you and knows that you have to be in a hospital for that.
I can't see why you can't stay and participate in on good terms without...
Because I was raped. going to kindergarten about 5 times.
Well, that was a few years
Okay,
ago.
let me give it to you a different way. How long has it been since I dreamed I was there in hillbilly heaven? Or how long has it been since Town Without Pity for rape? Or how long has it been since The Man Who Shot Liberty Valance?
My first impression of his family was the one I have in a lot of these cases, and that's that they're like a group of people that have been struck by lightning. Their son has developed a terrible illness, has been through lots of treatment, and has not gotten much better. And they feel devastated by it.
So let's talk about Gerald's mental status exam. He looks bizarre with that lock of hair on his head that he's playing with, twirling around. He's got some motor agitation. We call this a mannerism, where he's twirling his hair on top of his head, something that he's doing for no apparent purpose. He's suspicious of the interviewers and of his mother. His speech is spontaneous, at times it's loud and pressured, at times it's a monotone. He's very irritable. His affect is flat. Although he's irritable, you can see that his facial features don't really change at all. And he's got a thought process with derailment, clanging, makes up new words, like this man is playing boogie woogie with me. And there's, even though he's using a lot of words, there's complete poverty of content. In thought content, he does seem to have delusions of persecution. He does seem to have hallucinations, although none currently. And the examiner did not evaluate suicidality or homicidality. And remember, whenever you describe thought content, you need these 4 things to be mentioned: presence or absence of delusions, hallucinations, suicidality, and violent ideation. His cognition appears grossly intact, but he's using a lot of metaphors with unclear meaning, suggesting that there is a problem in abstraction. His insight and judgment are poor. So you can see he hits all of the elements, except for perhaps negative symptoms. He inhibits all the symptoms, cluster symptoms of schizophrenia. Let's talk a little bit more about negative symptoms. That's the 5th classification here, negative symptoms. So positive symptoms, we refer to hallucinations, delusions, bizarre behavior, and a thought disorder with all that rambling and loose associations. Negative symptoms, flat affect. They have people with a few words. They don't talk much. They have no, avolition means no motivation. They're apathetic about everything. They don't care to be around people, and they don't experience pleasure. And it turns out that schizophrenic that has primarily negative symptoms has a far worse prognosis than one who has only positive symptoms. So this is about 1% of the population, almost always before the age of 30 for men, but women have a second peak incidence in their 50s. It's more common in lower socioeconomic groups and in urban areas, and higher latitudes have higher prevalence. That's interesting. We'll talk about that shortly. So here's the age of onset, and you can see with men, 90% are occurring before the age of 30 for men, and for women you have this little blip up around 50 years old. The prodrome phase can be months to a year or 2 prior to the psychotic break. So these are usually in kids in high school. A kid who is otherwise sociable becomes more and more isolated, stops caring so much about his or her hygiene, academic performance declines. There may be some peculiar behavior or strange affect at times, and this can be months or years prior to the psychotic break. The active phase is the psychotic break, and onset can be either gradual or sudden, with the hallucinations and delusions and disorganized behavior, and that's where medical intervention is usually sought. The residual phase is when the active phase symptoms have resolved, and then the person goes back to their prodromal phase, and they may neglect their appearance, they don't want to have contact with other people, but occasionally there are those who get treated and are able to, go back into society. I would say from my own experience, maybe 10% of schizophrenics can actually go back to work after they've been treated. usually not a very complicated job, but if you've got brilliant people like Larry Nash, who become schizophrenic, they can still, especially with treatment, produce remarkable work. Okay, so residual phase we talked about, and then of course at any point a person can become psychotic again, usually when there's a stressor. So one study commonly cited is this 20-year longitudinal study of just 139 patients, with 75% patients had severe decline, 2% had preserved function, and 23% with moderate deficits. And the literature is all over the place with this. I mean, I've seen some where 30 to 50% actually get better and don't have further psychotic episodes. But that's probably because they were misclassified. They may have actually been bipolars, or they may have been people with briefer psychotic periods, not the full 6 months. Prognostic indicators: a good prognosis, a good response to treatment is acute onset, no prodrome. Good functioning before becoming ill. The older the age of onset, much better. No family history of schizophrenia is good. The medication response is good. Mostly positive symptoms and a higher IQ. The opposite of all those leads to a poor prognosis. Now, we call schizophrenia because they meet those DSM-5 criteria, but it doesn't mean that they're all caused by the same thing. Undoubtedly, this is a heterogeneous collection of disorders that meet those DSM-5 criteria, but are multifactorial, and many cases of schizophrenia will be found to have different causes than other types of schizophrenia. The reality is we don't know really why certain psychiatric disorders exist, but we have some clues. Now, some of the psychiatrists from previous generations, like Kraepelin and Freud, believed it was a neurologic disorder, but many psychoanalytic theories thought that this was the fault of the parents that a kid became psychotic. These have been completely discredited. We now believe it, like Freud did, is a neurologic disorder, and I mentioned it's heterogeneous in nature, meaning this is not just one biological cause of schizophrenia, but there are many different causes, and that schizophrenia is most likely not the same illness between one person and the next. And we believe that the onset of the schizophrenic process occurs in utero. One of the main things you're going to see in the brain views of schizophrenia is the enlarged lateral ventricles. So that's a big clue if you ever see it on an exam. The enlarged ventricles are characteristic of the brains of schizophrenics. These others, I would say the frontal cortex thinning is also found, decreased hippocampal volume. We see that with both depression and PTSD, and the decreased size of the thalamus. But the ventricular enlargement is the one that you're most likely to be asked about. So the dopaminergic system seems to be critical in the pathophysiology of psychosis. There are 4 dopaminergic pathways. We have here the mesocortical pathway. We've got the tubuloinfundibular pathway. We've got the pathway that goes into the basal ganglia, which is the nigrostriatal pathway. So, and also, pathway that goes to the limbic system is the mesolimbic pathway. So 4 major dopaminergic pathways. What we think is going on a very basic level is hyperdopaminergic activity in the mesolimbic system, which causes all these symptoms of delusions, hallucinations, and abnormal emotions and thoughts. And what we have decreased dopaminergic function in the mesocortical tract. And because of that, you get a lot of negative symptoms. If the dopamine is not being transmitted appropriately to the frontal lobe, you're going to have poverty of thought, many of the negative symptoms, and even a thought disorder. So we just discussed this. Some of the evidence of this theory is that amphetamines, which increase dopamine activity, can produce psychotic symptoms that are indistinguishable from schizophrenia. Amphetamines can exacerbate schizophrenia. And we know that antipsychotic drugs that work by blocking dopamine receptors do very well. In fact, they do very well with the mesolimbic pathway, but since there's already hypodopaminergic functioning in the mesocortical pathway, the older antipsychotics that are dopamine blockers don't really work for negative symptoms. The problem is that not all schizophrenics respond to dopamine blockers, and we have drugs that target other neurotransmitter systems can cause psychosis. LSD is a serotonin agonist, and it produces vivid hallucinations. And it's visual, which is rare in schizophrenia. Auditory is really the most common type of hallucinations in schizophrenia. But it can also cause delusions, and sometimes it can be delusions that are indistinguishable from those in schizophrenia. Well, that tells us that the serotonergic system has to be involved. And the newer atypical antipsychotics, in addition to blocking dopamine receptors, are also blocking postsynaptic serotonin receptors, again suggesting that serotonin is somehow involved in the psychotic process. But hey, antidepressants increase serotonergic activity but don't cause psychosis. And the older traditional antipsychotics that worked had very little effect on the serotonin system. And as I've said before, that glutamate is the next big hot thing in psychiatry. It's an excitatory neurotransmitter. PCP is a glutamate antagonist, and it can induce positive and negative psychotic symptoms indistinguishable from schizophrenia. It turns out that glutamate activity indirectly controls dopamine levels in the mesocortical and mesolimbic system. And there are new drugs that upregulate glutamate activity that we're working on, not only to be effective treatments for depression, but also effective treatments for positive and negative symptoms of schizophrenia. So GABA also seems to have a role in schizophrenia. So GABA, as you know, is the main inhibitory neurotransmitter, and it is synthesized from glutamate. And this is via an enzyme, glutamic acid decarboxylase. In the brains of schizophrenics in the prefrontal cortex, we find decreased messenger RNA that codes for this enzyme, glutamate acid decarboxylase. And when that happens, that means glutamate cannot be metabolized into GABA. And so you're missing the inhibitory neurotransmitter in a key area of the brain, in the mesolimbic dopamine system. And when you have GABA deficiency, you're not inhibiting the mesolimbic dopamine system, and that's where you get the hyperdopaminergic mesolimbic pathway. And I'll show this a little bit more clearer. So here we have the mesolimbic pathway, where you've got a glutamate neuron from the cortex coming down and exciting the GABA neuron. And then you've got the mesolimbic pathway, which is a dopaminergic neuron connecting these two. Now, what happens when you've got glutamate deficiency? You have the message coming down here, but now it is not stimulating GABA release, and so you're losing your inhibition of the mesolimbic pathway, and then you've got hyperdopaminergic input in the mesolimbic system. Now let's look at the cortex. Here you've got a glutamate neuron coming down, and now there's no GABA mediator, so as a person becomes glutamate deficient, it decreases activity in the mesocortical pathway, and so you have the negative symptoms because nothing's going on up here. So glutamate indirectly controls dopamine release in these two pathways. There is some evidence that the development of schizophrenia occurs in utero. There is decreased production of proteins that are essential for dendritic arborization, and the number of dendritic spines is reduced in the prefrontal cortex in schizophrenia. And you can even see some subtle signs of a neurologic disorder in children who later become schizophrenic. This abnormality is in eye tracking, hand control, coordination, speech, and there's an increased risk of left-handedness in children who later become schizophrenic. So as the development of the brain begins in utero and then continues up until the 20s, any pathological process that began in utero and that continues can manifest itself later on, 18, 20 years later. There's a high genetic relationship with schizophrenia, and you can see the general population, 1%. If you have a first cousin with schizophrenia, then you've got a 2% risk. Going all the way up, if you've got an identical twin, it's not 100%, there's a 50% concordance rate. With fraternal twins, closer to 20% concordant rate. Patient of mine's mother was schizophrenic, and she wanted to have a child. And her question to me is, what's the chance that my child is going to be schizophrenic? So look for grandchildren right here. I told her you have a 5% chance that your baby or your child, if you have one, will have schizophrenia, which means 95% chance you'll be fine. So it's so interesting because you can look down, does it pass through generations? So take monozygotic twins. You look at the child of the affected twin has a 12% chance of being schizophrenic, whereas a child of the unaffected twin has a 7% chance. So it's increased risk of a child from the unaffected twin, but not as high as the child of the affected twin. And you see something similar with the dizygotic twins. The affected child in the affected twin is 17%, and the risk of the affected child in the discordant twin is 2%, which is only double the general population. Adoption does not alter this risk. It's very clear this is not an environmental or cultural disorder. This is strictly, I can't say strictly genetic, but is primarily genetic. And we currently believe in the polygenic threshold model, which means there are many different genes that code for neural development, and that several would have to go wrong in concert to actually develop the brain into what is known as schizophrenia. There's definitely gene-environment interaction, so I don't mean to say this is all genetic, because environmental disturbances can trigger schizophrenia. For example, we know now that heavy marijuana use in adolescence can increase the risk of development of schizophrenia. And these are probably in adolescents who have the genetic predilection for psychosis, which would have never come had they not been smoking weed. So there's a gene-environment interaction, and it's a polygenic disease. Risk factors, people in developing countries, a father above the age of 40, births in the winter or spring. If there are any birth complications, that can be a risk factor. Living in an urban area gives you an increased risk, and first and second generation migrants have an increased risk of developing schizophrenia, and then we talked about marijuana. So what about this being more likely to have been born in the winter or the spring? A number of studies have concluded that it's influenza, when the mother is affected with influenza while the baby's in utero, that has associated with the increased risk if it occurred in the second trimester. And so you here look at the number of schizophrenic births, and you see that between January and May is where you have this huge spike in the number of schizophrenic births. And you can see kind of the same thing with flu epidemics in terms of the months after the start of an epidemic. You can see how the number of schizophrenic births goes way up between 4 and 8 months, which is just around the time of the second trimester. So if the mom is infected with the flu in the second trimester, she has a higher risk of having a schizophrenic baby. Schizophrenics have medical illnesses just like the rest of us, and so I'm sure you'll all be treating patients with schizophrenia. But things to be on the lookout specifically: tuberculosis, HIV, Hep C. Those are disorders of people with homelessness and IV drug users. Diabetes is more common, probably due to the poor diet, lack of exercise. There is an increase in seizure disorders. There is an increased risk in coronary artery disease. interestingly decreased risk of certain autoimmune diseases like rheumatoid arthritis. Their life expectancy is 10 to 15 years below the general population. It's primarily via medical illness, not via suicide. Comorbid substance abuse is very common. There's a 10% up to 15% risk of suicide, dying by suicide. And then chronic exposure to antipsychotics can cause tardive dyskinesia, which is a movement disorder I showed you in the first lecture on the mental status exam. And interestingly, even though we think it's a side effect of our antidopaminergic drugs, it's been described even before the development of antipsychotic drugs that schizophrenics would develop these abnormal movements, tardive dyskinesia. All right, so here's a little question for you. So putative causes of schizophrenia include all the following except in utero exposure, parental neglect, genetic factors, or frequent marijuana use. Parental neglect is not a factor in the development of schizophrenia. It may be a factor in depression or anxiety, but not in schizophrenia. Subtypes have been removed from DSM-5, but you might have heard or you might hear people talk about a patient with catatonic schizophrenia or chronic paranoid schizophrenia. Those are vestiges. Those are terms or vestiges of DSM-4 and DSM-5. They got rid of the 5 subtypes. There are probably dozens of subtypes of schizophrenia, but the 5 categories that we have are, again, they're only phenotypes, and there may be multiple ways in which people developed that particular constellation of symptoms. So until the 1950s, there were no antipsychotics, and so people would have to be in institutions that were often dilapidated, unsanitary, and in cases cruel to the patients. Thorazine, or chlorpromazine, let's go back there. I don't want to mess up a drug's name. It doesn't look professional. Okay. So treatment of schizophrenia. Before the development of antipsychotic drugs, these people had no choice but to be in institutions, usually filthy, dilapidated, unsanitary conditions, with few exceptions. But once chlorpromazine or thorazine was discovered as effective, it basically transformed all of these institutions as people could then leave and go live in the community. They'd still have some deficits, but they were well enough that they could be absorbed by the community. Many of them, of course, ended up being homeless, but still this was a revolutionary achievement to have a drug that could help these people. These days, most schizophrenics are treated as outpatients. So, and again, in your psychopharmacology lectures, you'll hear all about this, but important for you to know about the first generation and the second generation antipsychotics. Second generation is different in that they block D2 and D4 receptors, but also serotonin 2A receptors. There's a new antipsychotic that just came out that's FDA approved for patients with Parkinson's related psychosis. And this is solely a serotonin A antagonist. There's absolutely no action on dopaminergic activity. Very interesting. Right now it's just restricted to patients with Parkinson's disease or Lewy body dementia, which is kind of a Parkinson-like dementia. So when these antipsychotics came out, the new ones, they were also considered revolutionary because no longer did we have to worry about all of the movement disorders that occur with the older antipsychotics. And drug companies did these very nice studies showing that these drugs were superior in treating schizophrenia, positive symptoms, and they said negative symptoms. So you had all these articles published showing how the newer antipsychotics took care of the negative symptoms of schizophrenia. What happened? Government came in and did its own study called the CATIE trial, and this is an important trial for you to know about. So 1,600 participants were randomized to different antipsychotics, as you see right over here. If they didn't respond to any of those, and I'll just say, in these antipsychotics, you've got the atypical antipsychotics, and you've got an old antipsychotic, perfenazine. Phase 2, anyone who didn't respond to phase 1 could choose either clozapine or another antipsychotic, or ziprasidone and another antipsychotic. So there were 2 different pathways. Anyone who did not respond here would go to phase 3, and here they had a bunch of other choices. So the question is, did any of these drugs do better than any other? Well, before I even get to that, 3/4 of patients discontinued their medications before the 18-month trial ended. I mean, that's remarkable. And often the endpoint, the primary endpoint for these studies is the patient still taking the drug? Because if the patient's still taking a drug, that means usually that the benefits outweigh the side effects. So you can actually look at that as a primary endpoint in your study. In any case, the discontinuation rates were equal among atypical antipsychotics versus the typical antipsychotic profenazine. The lowest discontinuation rate was with olanzapine, which had the highest burden of the metabolic syndrome, tremendous weight gain especially. And perfenazine, which is the typical antipsychotic, had the highest rate of extrapyramidal symptoms, which is what we expected. But there was no difference in efficacy. In phase 2, comparing the atypical antipsychotics to each other, we see here that after 18 months, you look at the discontinuation, this is people continuing to take the drug, and look how horrible this is in terms of the drop-off by 18 months. But one drug seemed to be better than the others, the green one here, because fewer people discontinued it, and that's clozapine. So what the Katie trial showed us is that all antipsychotics are equal except clozapine, which works in this case much better in those who have not responded to the initial trial of antipsychotic. None of the other meds have any substantial advantage over the other. Clozapine is a unique drug. It's very dirty, it has so many side effects, some potentially lethal side effects. On the other hand, it's effective in conditions where all the other drugs don't work, and it's got an FDA-approved label for decreasing suicide in patients with schizophrenia or schizoaffective disorder. It also has some effectiveness for negative symptoms, unlike any of the other drugs. It's the least likely to cause tardive dyskinesia, but like I said earlier, it has the most toxicity of any antipsychotic drug. Here's a list of the common side effects of antipsychotics. Again, I think you all will learn about this in the pharmacology section. Here are the life-threatening consequences, and you see clozapine can cause white blood cells to plummet, seizures can occur, arrhythmia and sudden cardiac death can occur with many antipsychotics, neuroleptic malignant syndrome, and even stroke. All of these have been described with antipsychotics.